Here it
So
is.
thanks, yeah, wonderful. Thanks everyone. So for all of you who do not know me, I'm one of the faculty members with the Brookdale Department of Geriatrics and Palliative Medicine. I am an internist, hospitalist, geriatrician, and also a pediatrician. And I'm here, I was invited to talk about just the basics of pain management 101. Next slide. So I think we all know that pain is such a subjective symptom. And so the gold standard for pain is really self-report, right? There's really no other way to measure pain, not even vital signs, not even some of the findings that we see in like scans and so forth. Those objective data can help guide, but they are not the definitive way to assess or to identify that pain is in fact real. Pain is real for every single patient. And again, it's self-report. So we just need to keep an open mind. And in this anecdotal slide, you know, it says here, a smile doesn't mean that they're not in pain. And a smile means that oftentimes people with chronic pain try to live their lives best with the pain that they have. Next slide. So over the next 50 minutes or so, we are going to just talk about, you know, the pain experience, just touch on what that means, some basic pathophysiology of pain as a symptom. We're also going to talk about, you know, how to assess pain, stepladder to pain management as well, looking at the World Health Organization stepladder for pain. And definitely the crux of this talk is really about opioids, looking at their basic pharmacology, the pharmacokinetics, some dosing guidelines, and hopefully by the end of the session can, in fact, help you guys be more confident in managing patients with pain using opioids with some practice cases. The disclaimer that I have on here is that, you know, some of these information might already be familiar to you. And so I apologize in advance if this is too basic. However, we can always learn, you know, using some refresher courses, even if we're advanced in our training. Next slide. So this is a typical case, right? You have an 83-year-old female with some osteoarthritic pain, hypertension, comes in with a 3-week history of left hip pain and low back pain. The pain was described as dull, non-radiating, maybe a questionable parastatic symptoms with some pins and needles. Your imaging confirms that this person has osteoarthritis with some spinal stenosis of the lumbar spine. Perhaps you're questioning whether that spinal stenosis is impinging on some nerves, and perhaps neuropathic pain is one of those types of pain that you're also thinking about. So you start them on scheduled Tylenol, which we often do, particularly in our geriatric patients 65 and above. It's probably the least invasive and the most basic medications without significant adverse effects for as long as you don't reach the ceiling effect. And you also add other non-pharmacologic interventions. And I think the point of this vignette is to ensure that when you're managing pain, you're not only thinking about medications per se, but we also need to think about non-pharmacologic interventions like physical therapy, some heating and cold modalities, and another medication that you can also try is Lidocaine Patch, which is often utilized in the hospital setting. Next slide. So we're going to talk about, so really I divided this into two parts. The first part is just basics of pain, and then the second part is really that of opioids and some practice cases along that. So pain has been defined by the International Association for the Study of Pain in 1994 and then revised in 2012. That it is an unpleasant sensory and emotional experience associated with actual or even potential tissue damage or described in terms of such damage. Next slide. And when we say total pain experience, we're not only talking about the physical pain itself. When we're starting patients on pain medications, and we've continued to optimize and escalate on the pain medications, and we observe that no amount of pain medications appear to control the pain, then we need to think about other facets of or other dimensions of the pain experience. Perhaps there's a little component of social pain. Perhaps there's a major component of psychological pain. And oftentimes with people with advanced illnesses, there could be an element of serious spiritual pain. So definitely when we think about the total pain experience, this includes multiple dimensions and it's not solely physical pain. However, for the purposes of this session, my focus is that of physical pain, because guess what? You can't really tackle social, psychological, and spiritual pain if we don't have a good handle of physical pain, right? Because then the patient would not be able to speak to you or engage in your conversation. Next slide. Oh, and before I forget, as Sophia is going through that, the concept of total pain was actually thought by Cicely Saunders, who is considered the mother of the modern hospice movement. So she's really a great, a great physician who is actually also a social worker, and believe it or not, she was also a nurse. So she did all of this training, and so it's not rocket science that she kind of thought about total pain in this holistic realm, because she's the embodiment of all of these dimensions. So just a little overview of the pathophysiology of pain, and I'm not going to go into the specifics. I'm pretty sure you guys know. Our pain experience comes from different stimuli. And for the most part, the first point of contact is really our skin, which has your different receptors. You have your opioid receptors in the peripheral skin, as well as in the central nervous system, of which the effect is, for opioids, it's really more a central nervous system effect. And the skin has different receptors. As I mentioned, there's also different corpuscles, like the Pacinian corpuscles, let's say, for pressure. There's also the Reisner's corpuscle for temperature and so forth. And when you apply a painful stimulus, it goes into the nerve endings that eventually converge into a bundle of neurons, right? In your primary afferent axons, they go into the dorsal root ganglion of the spinal cord, and then eventually through the spinothalamic tract will then go to the brain. And the two important components of the brain are really the thalamus, where it is the convergence of all of these stimulation, nerve impulses, right, from the painful stimulation that initiated the cascade, and then all the way up to the brain, to the somatosensory cortex, which is in the cerebral cortex. And then from the brain, it goes back down to the thalamus, and then back to the spinal cord, and then back to your skin. And then you have the oohs and the ahs and the aches and pains that people experience when they are stimulated by a painful stimulus. On the other hand, pain is not only in the skin organ, but also that you can also experience that in the hollow organs, the visceral organs, such as the liver, the small intestine, and so forth. And it does have the same type of transmission, except that you have different checkpoints, so to speak. You have your afferent axons going into your sympathetic ganglions, and then goes into the spinothalamic tract onto the cerebrum. Next slide. So what are the general types of pain? So the first one is nociceptive, which is further divided into your somatic and also your visceral pain. So let's just take a moment there. So for somatic pain, these are typically, your striated muscles that are, sort of affected or implicated as the first point of contact. And, you could describe somatic pain as, somebody with sharp pain, knife-like pain, vice-like pain, and so forth. And so it's usually localizable. It's a certain area, in your body that is specific with, perhaps striated muscles and so forth. And visceral pain, on the other hand, in contradistinction, is more the smooth muscle lining, all the different other organs. So for the most part, your gut, the organs in your gut are the typical organs that are implicated, or the recipients of the pain, or not the recipients, but also the trigger of some of this painful experience. And then the second part is neuropathic pain, which is really could be central or peripheral. So common descriptors are shooting, pins and needles, electrifying pain, even a burning sensation. The third type of pain is really a mixture of nociceptive and neuropathic. And so it is not only purely a solely nociceptive or neuropathic. For the most part, it's a combination of both. And then the last is psychogenic, which is really a diagnosis of exclusion. And we really try not to, say that the person has psychogenic pain unless we're absolutely sure that they do have psychogenic pain. And you can only do so by, reviewing all the data at hand, and you can't really find a single form of, potential trigger for pain. Next slide. So in terms of the timing or the, the timing of pain and the duration of pain, we usually divide them into three, categories. You have your acute, subacute, and chronic. So usually with acute, you have less than 6 weeks, subacute is 6 to 12, and chronic is more than 12 weeks. Some variation of this is you can just pretty much just use the magic number 6 weeks. If it's less than 6, it's acute, and more than 6, it's chronic, if you don't want to have the subacute category in it. But I think that apart from the timing and duration, we also need to know the intensity and also the associated symptoms. Next slide. So pain is significantly impactful to any person who is experiencing it. And I think that, there are a lot of drastic consequences for, uncontrolled pain, from a decrease in functionality to an overall impairment in quality of life. It can also cause recurrent falls, depression, isolation, or decreased socialization. It can also cause delirium or cognitive dysfunction. No, I'm sorry, just go back to that. And it can also cause sleep disturbances. It can increase cost and utilization of health resources, polypharmacy, as well as caregiver stress. So we know from this slide that it is something that we need to pay attention. And you've all heard this, that pain is considered the 5th vital sign because of the significant effect on multiple facets of one's life. Next slide. So when you're doing an assessment for pain, one mnemonic that I think we're all familiar with is this PQR-STU. And so whenever you're assessing pain, please make sure to put this assessment in your documentation, because it will really help us and help you determine what sort of medications is appropriate. So P stands for palliating or precipitating factors. Q stands for quality or the nature of pain. R stands for radiation or pattern or region of pain, the location. S stands for severity or site, as well as associated symptoms. T is the temporality of the pain. Is this pain constant or intermittent? When is the timing? And then U is really a misnomer here. It's just really emphasizing that how pain affects the person, how it affects you, what quality of life metrics are implicated when somebody has under controlled pain. Next slide. Along with your PQR-STU, which is part of your pain history, when you're doing your pain assessment, you can then use different tools, such as your verbal descriptor scale. What is your pain? Mild, moderate, severe, very severe. The one that we are commonly using in our health system is a numerical scale, right? From 0 to 10, 0, no pain, 5, somewhere in the middle, 10, severe pain. Where is your level of pain? You can also use the visual analog scale, where you draw a straight line and then you put like 2 points, one on the left, one on the right. The farthest right means that you have severe pain. The farthest left means no pain. And for somebody, let's say, who is not educated or illiterate or have some cognitive impairment, then perhaps or developmental delay, you can use the visual analog scale to kind of assess for as long as they don't have any vision problems. And then we also have the Wong-Baker Faces Pain Scale, which we use a lot in the pediatric population, as well as those who are developmentally delayed adults and also with people with cognitive impairment. Next slide. However, in advanced dementia, we have what we call this pain ad scale, where we're really, for the most part, focused on nonverbal descriptors of the pain experience, whether it's the breathing pattern or the vocalization, the facial expression, the body language, and the consolability of the patient. So it's almost like an equivalent of the APGAR scoring in pediatrics, but not quite, because certainly we're not assessing pain using the APGAR scoring. However, for our older adults with advanced dementia, this is one of the scales that you can use, and you just need to total, and the higher the score, that's the way to stratify whether they have mild, moderate, severe pain. Next slide. So I hope that you are also privy to the World Health Organization ladder for pain management, which was actually created back in the 80s by the World Health Organization, really targeting or tailoring pharmacotherapies to the severity of pain and also to the origin of the pain. So it's usually 3 tiered, steps 1, 2, and 3. So step 1 is comprised of using non-opioids and adjuvants. Step 2 are weak opioids plus non-opioid agents and an adjuvant. And then step 3 is strong opioids, non-opioids, and an adjuvant. So when we talk about an adjuvant is a class or classes of medications that can potentiate the effect of the opioids as far as pain control is concerned. But also, it is important to note that the adjuvants are also primarily utilized for neuropathic pain per se, because opioids in and of itself are not the number one class of medications that we use in neuropathic pain specifically, because we have other types of receptors that are implicated, not just the mu, delta, and kappa. We have the NMDA receptors, for one, and some of the other calcium channels and so forth. Next slide. So then, so I'm sorry, can you go back one slide? Yeah. So the World Health Organization, much more specifically, when you're looking at mild, moderate, or severe pain, using your numeric pain score, you can kind of, then figure out from your clinical judgment whether you're going to give Tylenol or maybe some Percocet, or you're going to give some morphine or hydromorphone based on the numeric pain score. So if you have mild pain, that's usually pain score of 1 to 3, moderate pain is a score of 4 to 6, and severe pain is 7 to 10. So if you have mild pain, you usually start with Tylenol and NSAIDs. And then for moderate pain, you can do combinations of opioids and potentially acetaminophen, like Percocet, Vicodin. You can also use tramadol here. And then finally, for severe pain, you can use your pure opioids. Now, your adjuvant examples for neuropathic pain, as you guys know, are some tricyclic antidepressants like doxepin. You can also use gabapentinoids, gabapentin, and pregabalin. You can also use anticonvulsants like phenobarbital or trileptal. So there are, other adjuvants there are a lot of adjuvant classes that you can use. You can even use steroids, bisphosphonates, particularly those individuals with bony metastases and osseous lesions from their cancer, those are medications that can be used as well. Next slide. So the problem with a lot of these combination opioids has to do with the fact that they have acetaminophen, right? And we know that Tylenol in and of itself has a ceiling effect. So therefore, ceiling effect means that it's the maximum that you can provide without experiencing any adverse effects. And when you go beyond the ceiling effect, then that's the problem. That's when the problem lies. And then you can cause or potentially induce hepatic necrosis and hepatic injury just by use of Tylenol. And for people who have Tylenol toxicity, this is what actually will happen to them. So for younger adults, really the maximum that we can give is about 4 grams. For older adults, it's about 3 grams. And for people with stable liver diseases, for as long as they don't have any acute transaminitis, the 2-gram limit is potentially within acceptable limits. Next slide. So now we've covered some of the basics of part 1, which is just the pain as an experience. And then now we're going to switch gears into opioid prescribing. So the 3 main receptors for our opioids are your mu, kappa, and delta. And the mechanism is really when our opioids bind to these receptors, what they do is they modulate pain control by inhibiting the calcium channels and preventing or inducing the release of neurotransmitters. And I'm not going to go into the detail of each of the opioid receptors because they're pretty much detailed here and you have access to this slide. But pretty much, when your opioids are bound to your opioid receptors, you do have, adverse effects that come with the territory with just any medication. That's next slide. So when you use opioids, there are, again, multiple checkpoints here that opioids can be really helpful. The first line is that we do have peripheral opioid receptors. So when opioids bind to our peripheral receptors, then it can definitely target the pain control, target the pain source, if we know that the pain source is along the skin and surface level. But the inhibition for opioids as far as pain control has to do with its effect and also the potential effect of the GABAergic activity as a neurotransmitter that is inhibitory in that case. So definitely the spinal cord as well as the central nervous system is ultimately what opioids will really hit or target, so that it can modulate the pain by inhibiting the responses that come with this. For the same reason that we have given you earlier about the pathophysiology of pain, that it's through the central nervous system of which the spinal cord and the brain are part of, that the reaction to a painful stimulus happens. And so that's what we want to inhibit as well, this at the level of the spinal cord and also at the level of the cortex. Next slide. So I could not overemphasize this enough, that there are significant adverse effects for opioids, from GI, nausea, vomiting, constipation, which are quite common, to autonomic, manifestations such as urinary retention, even postural hypotension. Cutaneous is a common effect like pruritus and even profuse sweating. And I think the most feared one is respiratory depression, right? And we know that the CNS effect comes with the territory of opioids because of its central acting effects. However, we need to also make sure that when we're taking care of our patients and they're identifying that they have an allergy to an opioid, we have to ensure that this allergy is either not a true allergy or not a true allergy. And we define a true allergy as IgE mediated. It's usually presents with rash, hives, dizziness, stridor, or urticaria. I find this a lot in my day-to-day practice when I ask patients or when I provide recommendations and I say, I'll start you on some hydromorphone or morphine. And then they will say, well, I'm allergic to that. And, if I'm not astute enough to explore what that allergy is, I could buy into it and say, okay, we're not going to give you morphine and hydromorphone, when in fact, these medications are the most helpful for an individual's pain experience. So always try to explore, because for the most part, when you hear or when you see it on Epic and it says allergy, and then you ask the patient what their allergy is, what they will say is, I have nausea, or I have vomiting, or I get itchy. And that in and of itself is not a true allergy. Next slide. So we know that constipation is the most persistent problem. So whenever you're writing orders for opioids to start, make sure that they have a bowel laxative. Now, the bowel laxative does not need to be medication alone. You can also encourage them to drink, obviously plenty of water. And also you can use some, herbal remedies like prune juice that are bowel laxatives and just really increasing, fiber with liquid in the diet. Certainly, if we think that the diet is unreliable or the appetite is unreliable, we then need to start with either Senna or Miralax. We never use Colace. Colace is not a true laxative, so just start with either Senna or Miralax. And then the most lethal complication of use for opioids is respiratory depression. And we hear this a lot, particularly for people who are starting out in training. They would say something like, I'm not comfortable putting an opioid in because, I'm worried about respiratory depression. Well, the reality is that even though respiratory depression is the most lethal complication of opioids, I actually have not seen it happen unless you gave the wrong dose, too high of a dose, or too short of an interval. And this is the reason why we're having this lecture, is for you to be equipped with the skill set and the knowledge so that you will feel comfortable prescribing opioids and you will not, and I will not be hearing that concern that I'm not comfortable because, you know, I fear that this person is going to go into respiratory depression. I think we have to also be reminded that the patients come to us for a reason. They are in pain. And if we're uncomfortable with pain medication, then we won't be able to treat their pain because we're uncomfortable with it. So the way to mitigate that discomfort is really through education, practice, and developing that skill set. Next slide. So there are occasions when you have to do what we call opioid rotation. So what does this mean? So essentially what this means is that a person is exposed or has been taking, let's say, morphine. And then somewhere along the line, the time that the person is in the hospital, they start developing really adverse effects that is intractable, right? And you can't mitigate it with other pharmacotherapeutic agents. Or a person could start developing some weird, you know, central nervous system kind of adverse effects like myoclonic jerking, maybe some hallucinations. And then you're kind of noticing that as you're going up on the opioids, these adverse effects become much more noticeable, right? So you're going up from 10 milligrams to 15 milligrams of MSIR, for instance, and then now you're noticing that your pain is worse. They're having some hallucinations. Their body movement is a little bit jerky. You know, the one thought there is that, is this person suffering from what we call opioid-induced neurotoxicity? Meaning that they develop this neurotoxic condition as a result of going up on the opioids. And you know, in this slide, we've included several predisposing factors, whether it's dehydration, renal failure, which is really the more common cause of opioid neurotoxicity. And also when you're going up too fast, too quickly, and not giving time for the body to achieve steady state, that's when you'll really experience opioid neurotoxicity. A couple of things with opioid neurotoxicity are these constructs called allodynia and hyperalgesia. How do we distinguish one over the other? So allodynia is a painful experience to a non-painful stimulus. So when you use a wisp of cotton, let's say, and then you put it on the dorsum of the hand, and the patient just screams in pain, then that's allodynia. So that could be a sign of two things. One is opioid neurotoxicity if they're already on opioids, and then the other thing is it could be neuropathic pain from an unknown etiology as of yet for people who are not on opioids and developing allodynia. And then in contradistinction, you have this construct called hyperalgesia. So this is when you introduce pain in somebody who already has a painful experience. However, the response is exaggerated, like it's out of proportion. So let's say if you use like a hairpin or the tip of your pen. And maybe for some it can cause a little bit of pain, especially if the tip of the pen is really sharp. And then the individuals can then have this significant exaggerated pain experience. Then we also need to think about that this may be hyperalgesic effect of either the opioids, or again, if they're not taking opioids, then maybe it's a neuropathic experience from an underlying organic problem. Next slide. So the other thing that I also wanted to talk to you guys about is all these different constructs like addiction, physical dependence, tolerance, and pseudo-addiction. So addiction is actually a primary and chronic neurobiologic phenomenon that is characterized by the 4 C's, which I will go into later. And I think what I really wanted to impress here is that for as long as we're treating a patient for the pain experience that they have from their underlying illness, we should be confident in counseling our patients that they're not going to get addicted to opioids once we start them, because we are in fact, treating something that is related to their underlying disease. The physical dependence, on the other hand, is when your body gets acclimated to the use of opioids to the point that when you discontinue the opioids abruptly, or when you lower the dose, abruptly, then they develop withdrawal symptoms. Because what happens with opioids and opioid receptors is that once the opioids are bound to the receptors and you achieve steady state, then that's like a comfortable level where the two are closely tied, and one without the other makes the situation, really kind of haywire in terms of the relationship. So then people develop withdrawal symptoms from that. And for the most part, it's really autonomic dysfunction that happens. Tolerance is when your opioids are saturated with opioid receptors are saturated with your opioids, and we can see that there is no beneficial effect on the opioids being given. So that could herald potentially increasing the opioids, or maybe even switching to a different opioid if we feel that patients are already tolerant to it and are not getting the full effect. And then pseudo-addiction is not a true addiction, which is characterized by people with under-controlled pain and then are seeking additional relief with pain medications. Next slide. So the 4 C's in addiction, I wanted you to look at the 4 C's of addiction on the lower right. So the first C is impaired control of drug use. The second C is compulsive use of the medication. The third C is continued use despite the adverse consequences or despite harm. And then the last is craving when the drug is stopped. So you have to meet the 4 C's for you to label somebody as addicted or having an addiction problem. And I think that we also need to be mindful about labeling somebody with addiction, because addiction in and of itself is a very stigmatizing diagnosis. So unless we're really fulfilling the 4 C's, we shouldn't be using the word very loosely for our patients. Next slide. On the other hand, with pseudo-addiction, the point of this slide is that it's usually related to untreated pain. And so therefore they experience behaviors, or they express behaviors that are quite concerning. And so we hear this a lot as well, in our language. We oftentimes label people as drug seekers or frequent flyers and so forth. And the reality is that, again, before judging into conclusion, we have to figure out, are these individuals being given the right dose, the right medication, the right dosing interval, and so forth? Because if we're not doing that, then we're going to be in the habit of labeling them as pseudo-addicted. Next slide. And I've just outlined some of the reasons for undertreatment of pain. It could be inadequate knowledge or inappropriate attitudes of healthcare physicians, patient and family fears and misconceptions about pain and use of opioids, and also the barriers in the drug regulatory system, which are quite a lot, whether or not it's covered by insurance, whether you need prior authorization, also health system problems with the delivery of care. Some have poor access to opioids in certain areas of the country, and unfortunately. And so we need to be mindful of that, and also inadequate reimbursement for drugs and other therapies. So I think we need to just definitely treat chronic pain as best as we can, again, without judgment. So what are some of the general approaches to opioid management? So I don't think that you will be penalized if you wanted to start conservatively. So if you're the type of clinician who just wants to make sure that when you're using opioids, you're not causing significant effects, then still attempt to prescribe opioids, and you can start at a much more conservative dose and then kind of work your way up, so that you avoid giving naloxone, because everybody's jumping to naloxone when there's already concerns about oversedation and so forth. And also the geriatric specialty and specialists, actually, we all follow sort of the mantra of start low, go slow approach. And I think that this can be applicable not just in geriatrics, but also in internal medicine. And for younger adults, as I said, it's probably safer for you to start on a conservative dose and then kind of work your way up. Next slide. So let's look at how we calculate opioids now. So we're getting into the meat of this discussion. So some nuts and bolts about opioids in general. So there is no ceiling effect for opioids. So unlike Tylenol, when you reach a certain point, it's going to be bad for the liver primarily. So with opioids, there is no ceiling effect. However, probably there are rate limiting effects, and that's mostly driven by the adverse effects. Some adverse effects are just so intolerable for our patients that they themselves are gonna want to give up on opioids to treat their pain. So I think when that happens, again, we can have an open line of communication and kind of talk about different strategies to help mitigate their pain without using opioids. So one size does not fit all. And so we just need to be mindful of that. And also to avoid the use of meperidine and propoxyphene because of the significant neurotoxic and cardiotoxic effects that these medications have, especially for older and frail patients. And then the last thing that I wanted to point out in this slide is that naloxone, there is a place for naloxone. It's not a bad antidote. It's definitely, important. However, there is also a place for this, and it's usually when we're thinking about life-threatening respiratory depression, and that's when the respiratory rate is less than 8 or less than 10, and you're definitely seeing signs of somnolence and that's unarousable. Then you definitely need to use naloxone. Next slide. So in general, and if there's anything that I wanted you guys to take away and remember from this talk, this is it. This is the magic table, as I would call it. So for opioids that are given by mouth, per rectum, or sublingually, the onset is typically 30 minutes. The time to peak effect is about 60 minutes. And then the half-life is anywhere from 3 to 4 hours. On the other hand, for intravenous medications, the onset is usually less than 5 minutes. The time to peak is 10 to 15, and the half-life is 2 to 4 hours. So you can see in this table that oral medications and IV medications are really comparable in terms of their efficacy. So when you hear comments from the patients like, oh, please give me IV because it's better, that's not actually accurate. What's better about the IV is that it's quick onset of action. However, the half-life is pretty much similar to oral medications. But I think the two important pharmacokinetic parameters here is really the time to peak and the half-life, because that's when you'll figure out what the dosing is for opioids on the medical floor. Next slide. So this is just a graph of IV comparing all the different routes of administration, from IV to subcutaneous route, and also the oral and the per rectum, and we can and the half-life, and all of them converge all at the same time. It's really the onset and the time to peak, and the onset that distinguishes one over the other. Next slide. Sophia, next slide.
Yeah, sorry, just a second. There's something stuck here. Okay.
Yeah. So thank you. So intramuscular route is something that we should avoid because it's unreliable when it comes to its bioavailability, especially if you have a cachectic, sarcopenic, and emaciated patients. And also we have to think that intramuscular routes are quite painful, right? So if you've gotten your COVID shots and your flu shots, they're definitely painful. And so we try to avoid them in somebody who is already in pain. Next slide. Okay, so one of the other important concepts is differentiating an opioid naive versus an opioid tolerant patient. We define opioid tolerant patients as those individuals who have taken in at least 60 milligrams of oral morphine or its equivalent, whether it's hydromorphone, oxycodone, daily for at least 7 days. That's how you differentiate tolerant from naive. So if they are taking that amount, then they're considered tolerant, and if they're not, they're considered naive. Next slide. So the starting doses for opioid naive patients are anywhere as listed above. So for morphine, for instance, it's 2 to 5 milligrams IV and so forth. Next slide. However, for opioid naive patients, we do have what we call weight-based dosing. So we use the weight-based factor 0.03 to 0.05 milligrams per kilogram of actual body weight of IV morphine or equivalent. And this is pretty much applicable for older, frail patients, and even those who are younger and who have serious illnesses, who are cachectic and sarcopenic. However, for the younger ones, you can even go as high as 0.1 mg per kilogram of IV morphine or equivalent. So going back to the initial starting dose for morphine IV, which is anywhere from 2 to 5 milligrams, that was actually derived from the 0.03 to 0.05 milligram in a 70 kilogram person. So that's how you do it. So when you're using your opioids, when you're starting opioids now for people who are in pain, there's actually, it should not be a guessing game. Like, okay, I'm just gonna give 3 milligrams because this is quite the number. You can now use this weight-based equation to figure out what is my starting dose. And technically, you can really start anywhere from 0.03 to 0.1 mg per kilogram, depending on your the patient phenotype that you are taking care of. Next slide. And I think you all are aware about the equianalgesic opioid dosing. The prototype is morphine. And so therefore you have in this table the parenteral and also the oral routes and what the equivalent doses are. So morphine, so so for, let's say for morphine IV, the equianalgesic dose is 10 and oral is 30. And we know that IV is 3 times much more potent than its oral equivalent. Next slide. So how do we start the dosing per se? So number one is there are some considerations before you start opioids. You have to look at the renal and liver function. For the renal function, you all need to calculate the Cockcroft-Gault formula. And the magic number is 30 mL per minute. If it's 30 mL or more, that's the time that you will use morphine and morphine first. And hydromorphone should only really be used if your creatinine clearance is less than 30, or if your creatinine clearance is like on the border, let's say 40 or 35, and you know that the person has inadequate oral intake, and within the next couple of days, you figure out that the hydration status is going to be imperiled, right? Because of their underlying organic illnesses. Otherwise, we should all be using morphine first and not hydromorphone, because there's no basis that morphine is less efficacious than hydromorphone. The other thing that's also attractive about morphine is that it's effective, it's cheap, it's easy to use, it's available on formulary. So we should all be using morphine. One of the cultural nuances that I noticed when I first came on to Sinai was that everybody was using hydromorphone left and right. And we also see this a lot in some of our surgery colleagues as well, that for some reason they're much more comfortable with the hydromorphone than the morphine. And I don't think it's because that they know that both are necessarily like efficacious, but I think that morphine has developed this bad rap that it's only a drug at the end of life. When people think about morphine, that means that they're dying. And that is furthest from the truth. The other thing too is that people look at the number. So morphine 2 milligrams seems a lot higher than hydromorphone 0.2 milligrams, right? The 0.2 is the convincing factor there. And we all know that that's not necessarily the case either. Next slide. So this is the Cockcroft-Gault formula. You just need to punch it into your MedCalc or to your QX Calculate app. And also on your Epic charts, you'll be able to see that on the left-hand side where you see the basic information of your patients. Do not rely on the GFR that is on the labs per se, because it's actually using the MDRD equation, which is not what a lot of the pharmaceutical companies use. And the maximum that it can go up is more than 60. So it doesn't really give us anything. And the other thing too is that seemingly you might have a normal creatinine, but really they're abnormal when you calculate the creatinine clearance. Next slide. So how do you then decide what your dosing interval is? So we talked about this earlier. So for pure IV, you can use either the time to peak or the steady state. So on the medical floor, you can give it as often as Q1 because you can't do every 10 or 15 minutes on the medical floor unless you're on a pump. And then you also just need to think about when you're scheduling your medications, you can use the every 3 or every 4 hour mark because that coincides with the half-lives. And it takes about 4 to 5 half-lives to reach, for medications to be steady in your serum. Go back to the slide. No. Yep. And also for long-acting medications, for the most part, they are given every 12 hours. But when you have end-of-dose failure, then you give it every 8 hours. Next slide. So I think we need to understand that for chronic pain, there's usually persistent pain in the background, and then you have a breakthrough pain that happens. And breakthrough pain is distinguished from incident pain. Incident pain is when you're doing when there's a specific trigger, usually activity related, that makes the pain experience even worse. So, like I have a patient right now who's got acute myelogenous leukemia and developed an anal fissure. And he has some pain, from just by virtue of the fact that he has the anal fissure. And then when he defecates, then the pain becomes really worse. And so that's what we call incident pain, because it's incidental to the chronic pain that he already have. At baseline, he does still have chronic pain from the fissure itself and perhaps from the leukemia. As opposed to breakthrough pain, for breakthrough pain, the difference between breakthrough and incident pain is that it might not necessarily be associated with any type of trigger. You could just be like resting, and then all of a sudden you have pain, right? Even though you've gotten your scheduled doses an hour or two earlier. So that's kind of what breakthrough pain is. Next slide. Always ask the numeric pain score goal. A lot of the times, patients have this misconception that, if they come in with a pain score of 10 out of 10, our goal should be 0 out of 10. I think that eventually we should strive towards that goal. However, knowing now the pharmacokinetics, we know that you're not going to achieve steady state for both your IV and PO until you hit 4 to 5 half-lives, which is anywhere from 3 to 4 hours, which means that you need to give yourself a day to be able to achieve steady state levels. So you're not going to hit the 10 to the 0 goal without causing adverse effects. And that's where you'll end up with unarousable sedation and respiratory depression, because respiratory depression is always preceded by unarousable sedation. So one compromise could be, let's bring your pain down by 50% for as long as you're able to function and you're able to carry out your activities. And I think that's a reasonable objective. Next slide. So your guidelines for opioid naive patients. So you start with PRN dosing over 24 hours, right? So let's say you have a person who's in pain, you calculated the dose. Let's say the calculated dose, for ease of mathematics, you have a 70 kilogram person, you use the 0.03 milligrams per kilogram, you're gonna give 2 milligrams of morphine IV, keeping in mind that the creatinine clearance is greater than 30. So you start giving 2 milligrams, let's say at 9 a.m., right? When you first saw the patient. The next time that you will be checking the patient is at the 15th minute mark, right? Because the time to peak for IV is anywhere from 10 to 15 minutes. So at 9:15, so let's say the person's pain at 9 in the morning is 10 out of 10. And then at 9:15, you check in with the patient and the person says, my pain is 8 out of 10, right? And you've given 2 milligrams beforehand. So what you can do, which I will get into later, is the titration schedule. You can, for your next dose, you can increase the next dose by anywhere by 50 to 100% because the patient is still in moderate, severe pain. So once you've done your math and you've given them PRN medications, you total them over 24 hours. And then when you come in the next day, you convert them to like an oral medication if they're able to take orals. And you divide it by 2 or 3, depending on the long-acting agent that you're going to use. And for as long as there's no end-of-dose failures. For the most part, it has to be Q12 hours for Amiscontin or OxyContin. We try to avoid saying BID because BID does not equate to Q12. Next slide. And the one last thing here is that the PRN is always 10 to 15% of the 24-hour dose. Next slide. So here was the titration method that I shared with you. If it's mild to moderate pain, you increase the dose by 25 to 50%. If it's moderate to severe pain, you increase the dose by 50 to 100%. And the breakthrough dose is always calculated as 10 to 15% of the total daily dose or the 24-hour dosing. Next slide.
Dr. Javier, this is Sophia. Just a reminder, we have 10 more minutes.
Mm-hmm. Thank you. And then for your second titration method, let's say you've already put the patient on a standing dose. and a PRN dose. Because usually what you do is that when you have chronic pain, acute on chronic pain, you have a standing or around the clock dose, and then you also have a PRN or short acting dose. So what you do is you total everything, and then you just divide them accordingly. So if, let's say, you use MS-Contin 15Q12, and then the PRN is 5 milligrams, and the person had gotten 4 doses of that. So you multiply 5 times 4, that's 20, plus 15 times 2, 20 plus 30. So that's going to be 50 milligrams over 24 hours. And then you just divide it by 2, by 2 to make it Q12. So your dose will become 30 Q12, at that point. And then your PRN dose is 10 to 15% of the 60 milligrams that you put in. And so therefore your PRN dose should be anywhere from 6 to 10 milligrams. Next slide. Make sure that when you're also scheduling, especially for IV medications, like let's say you decided to schedule them, they're not ready for orals, you just wanted to schedule them for IV. So just put 2 milligrams IV every 4 hours around the clock, hold for respiration less than 10, and hold for unarousable sedation, and then patient may refuse. Next slide. For opioid tolerant patients, you don't have to use the weight-based dosing. What you can do is look at what they're already using now, total everything that they've gotten when they first came into the emergency room or when they first saw them on the floor. And then you just get the PRN dose, the 10 to 15% of the total daily dose. And that's what you use as your initial dose for your medication. And then you check up on them again in 15 minutes or so. And then you again use your titration schedule of mild to moderate, increase by 25 to 50, or moderate to severe, increase by 50 to 100%. Next slide. And then also just make sure to use the ecoanalgesic table when converting one opioid to another, and also adjust for incomplete cross tolerance. So what does this mean? So when you're converting, let's say from morphine to hydromorphone, instead of, once you get the product of the calculation, instead of giving the full 100%, you can reduce it by 50%, again, just to be on the conservative side so that you're not over doing the dosing of the medication. And this is pretty much applicable for people who are opioid tolerant and have been on pain medications for a long period of time. Next slide. And obviously, we need to adjust for opioid clearance as a function of dehydration, renal failure, liver failure, and even just frailty in general, and people not eating or drinking. So in this case, you could either decrease the dose or lengthen the interval. So instead of giving it every 4, you might want to give it every 6 or every 8 hours. Next slide. Next slide. So you have a patient who's 88, has a fracture. This is the same patient that we had from earlier, was getting some Tylenol, and now you've started the person on oxycodone PRN 5 every 4 hours, 6 doses of oxycodone. Next slide. You total everything basically, right? And then I'm sorry. Yeah, so you then figure out that this patient, was taking, was it 6 doses of 5 milligrams? So that's why it's 30 milligrams. And then you now start them on a long-acting medication. So you divide it by 2 to make it Q12. And then the PRN dosing is 10 to 15% of that, which is anywhere from 3 to 4.4 milligrams or 5 milligrams of oxycodone. Next slide. Then you just need to put some holding parameters so that, and this is another intervention that you can use so that you're not fearful of the oversedation that can then lead to respiratory depression, is actually putting holding parameters, and patient may refuse. Next slide. What else is missing? You need to put your bowel regimen, Senna, Miralax, Dulcolax. Next slide. Next slide. Next. So the same patient, right? So you put them on OxyContin and you have PRN oxycodone, you gave them 4 doses. Next slide. So this is the part where you total everything again, right? So now the new dose based on the total is, now it's 50 milligrams in total practically. So you're gonna start them on 25 every 12 hours, and then the oxycodone PRN is anywhere from 6 to 9 or 5 to 10, because Oxycodone doesn't come in 6. It comes in 2.5 and 5 and 10. Next slide. So I think this is probably the last teaching point here. So let's say the person develops dysphagia, and now you want to convert this this patient had received 6 doses of 5 milligrams of oxycodone, and you want to convert this into parenteral morphine. Next slide. So this is the equation. This is the last teaching point, and I think it's also really important for us when you're converting from one opioid to the next, right? So this person has been taking oxycodone. We don't have any IV oxycodone. Therefore, if they have dysphagia, they have nausea, vomiting, you want to convert that to IV morphine or IV hydromorphone. So on the left-hand side is the current opioid as the numerator, and then the equianalgesic dose of the current opioid. And then on the right-hand side is a 24-hour dose of your new opioid, but where you want to get to. And the equianalgesic dose of the new opioid is the denominator. Next slide. So you total everything for what this person got as an oral regimen. Next slide. And then you look at the equianalgesic table. So you know that the equianalgesic dose of oxycodone is 20. And you want to convert that to IV morphine. And we know the equianalgesic dose is 10. Next slide. You plug in all the numbers. So 70 milligrams of oxycodone was the total daily dose that this patient received. And then the denominator is 20, which we saw in the previous slide, equals X, which is the IV morphine that you want to get to. And then the equianalgesic dose is 10 because that's the EAD of morphine. So you just do your math. 70 times 10 divided by 20, so you'll arrive at 35 milligrams IV of morphine over 24 hours. Now, since you're converting from oxycodone to morphine, remember, you have to adjust for incomplete cross tolerance. So you divide 35 by 50%, so you'll end up with 17.5 or 18 milligrams of IV morphine. Next slide. And you have a couple of ways to administer this medication. The first one is you use a PCA. And then the second one is you just use scheduled dosing every 4 hours. So the 18 milligrams, if you wanted to give that every 4 hours, then you just 18 divided by 6. And that's how you arrive at the 6 milligrams every 4 hours. Or if you wanted to, or I think this was the 35, depending. So the other thing that I think I also wanted to tell you is that in exceptional cases, and when you're confident enough not to adjust for incomplete cross tolerance, because you can ignore the 50% reduction that's really applicable for people who continues to have severe pain or 10 out of 10 pain, even when you're converting from one opioid to the next. And then the final point here is that when you're doing the 35 milligrams, let's say you did not adjust for incomplete cross tolerance because the patient is in severe pain, you just divide 35 by 24 and you'll end up with 1.45 milligrams hourly or 2 milligrams an hour. And then you have to factor in all the different components of the PCA, which is you have a demand dose, which is usually 50 to 100% of the basal rate. You have a lockout of 10 minutes, which is equivalent to the time to peak of IVs, anywhere from 10 to 15 minutes. And you also have the clinician activated dose, which is twice the basal rate. That's why you ended up with 2, 1, and 4. And then if, let's say, you decided to just schedule it every 4 hours, then you divide 35 by 6. And that's how you ended up with 6 milligrams every 4 hours around the clock. That concludes the session. I don't know if we have time for questions, Sophia.
Sure.
So does anybody have any questions? You can either feel free to put them in the chat or just unmute yourselves and then ask the question. And they will have access to the slide set, right, Sophia?
Yeah, we can send it later.
Yes, please. Because sometimes this can take a little while. I know it's a lot of information and I don't really expect you to like understand everything. So definitely when you have a moment after the workshop to, review the slides, for me, it took me quite a while before I was really able to like master the use of opioids. So, just be patient with yourselves also.
Sounds good. If no questions right now, thank you, Dr. Javier. We'll take a short break before we restart with the workshop.